Hello, everyone. I'm very happy to welcome you again for today's webinar, multidisciplinary case discussions. I'm very happy again that three presenters are willing to contribute and prepare their cases. Again, nothing would be possible without your effort, your special effort, and to share your knowledge and your experience with the entire community. I would also like, of course, to thank the team, Eugen's team, who make this always possible, and also our sponsors who support us in our exchange. As the first presenter, I want to introduce Christian Rothermundt, a medical oncologist from Switzerland, and please just start.
Thank you, and I'm going to present the case of a patient. It's a spoiler, but with a pleomorphic liposarcoma. He presented this year as a 57-year-old man with a metabolic syndrome, obesity, dyslipidemia, pre-diabetes, and hypertension. And all this happened in April this year. He had an emergency consultation due to pain in the right buttock area. The patient reported that he had a tumor and that he had an MRI scan performed the previous day. And obviously we obtained the images. So I actually don't know if there is a radiologist on the panel, but I can just let you know that a large tumor was seen, 23.5 centimeters in diameter in the gluteal region. There was a cystic part and a solid part. And this is of importance for the further discussion. The sciatic nerve runs for a long distance in the immediate neighborhood of the medial dorsal edge of the tumor without signs of infiltration. So what is your next step? And I think this is open for discussion now.
So maybe Michelle, what would be your next step?
Yeah, I guess my video's off, but I would get a biopsy after I do my history and physical. And at that time, he has an MRI, I would order a CT chest. Sorry.
Your sound is a bit off, but I understood that we're doing a biopsy and a CT scan. So I'm going to proceed with my case. So we actually present all these patients to our sarcoma board. So the MRI was presented. Again, there was a discussion about the sciatic nerve, which is displaced, but not completely encased. Our radiologist said he thinks it's an undifferentiated pleomorphic sarcoma, and we planned a CT-guided biopsy. The biopsy path was marked, and we decided to use to perform a staging CT scan, but also abdomen and pelvis because of the large extent of the tumor. So this is the image of the CT-guided biopsy. I guess what's important in this case is that you try to get a part of the solid tumor and not only of the cystic part of the tumor. Any comments on the biopsy path? Bruno, would you have chosen the same, or would you have done it differently? I mean, I know that you only see this image now, but perhaps you can.
Sure. But in the end, it always depends, of course, on the surgical approach that you would do. And I think it could well fit, yes.
Okay. Dimo, you're also on the panel. Anything you would have done differently?
Well, so it's always difficult to just say anything about just one picture. And the CT-guided biopsies are also not so very dangerous in terms of tumor cell seeding. But if I look at the size of the tumor, I mean, it's great that they got the solid part of the tumor, but I think if I consider how I would do the resection, I would have more likely tried to put the biopsy path a little bit more laterally so that I don't have so many problems by the preparation of the lateral aspect of the tumor when I try to excise the biopsy path to make sure that I keep a little bit more of the skin, but that's really, complaining at a very, very, very high level.
I think that's important. And I have another question. How do you mark the biopsy area? Do you leave a mark?
So at least when we do CT guided biopsies, or when we do also ultrasound or shortcut biopsies, then my preferred approach is just to leave the suture in a place for the time of neoadjuvant treatment. In case it falls off by the time it does, then we will have a good marking of the biopsy. So I tell my patients we will not remove the suture, we'll leave it just in place, and then I know where the biopsy is.
Okay.
Actually,
Misha, how do you handle this?
Yeah, I would ask radiology to go for the solid component any way they could, and I don't deal with true cut biopsy. Like if the biopsy is not open, if it's a needle biopsy, core needle or a needle, but usually core needle, I just ignore it. I've never taken in my entire career, almost 20 years, excised a true cut or a core needle biopsy tract ever.
Okay. So, because we have to go through the whole case, but I think this is a really interesting aspect, and perhaps Bruno, I don't know if is this something you want to come back to at some point?
No, I mean, we can discuss. That's interesting. We never do it for soft tissue sarcomas. If it is irradiated, then I also ignore. We do not mark specifically the biopsy site, unless, just because of the scar, we see the scar. But if should I not see the scar, then I'm not very worried if there is a pre-op radiation. It's different for a bone sarcoma. And bone sarcoma, there, yeah, we usually excise it. Is that, Michelle, also?
Yeah, any neoadjuvant treatment, like if radiation or chemo, I would ignore the biopsy. So yeah, bone is different, but if there's neoadjuvant treatment, it's so hard to how do you find a needle track after
But sometimes we don't know whether we will perform neoadjuvant treatment, and I guess this is a part of the discussion in this case, whether it's...
Yeah,
so
that's a good point.
Dimo, you're raising your hand.
So of course, Michelle is absolutely right, as always. So there are good data in the literature saying that the risk of seeding in the needle biopsy is extremely low, and there are no data supporting that we need to excise the tract. The only thing for me is that I do have very, very, very rarely patients where I see that the biopsy tract, even if it's a needle biopsy or a true cut biopsy, more likely has been contaminated by some hematoma. So then I already start not feeling very comfortable with leaving the tract in situ. And more important for me is, I'm a very difficult person, so I always want everything to take place in the same order and the same way, so that I know that no possible errors can come in. So again, Michelle is absolutely right. And if the needle tract biopsy is at some point where it's very difficult to excise, then it's another discussion. But if I do it, if we do it at my center, then my preference is to do it where I would also do the open biopsy and excise it at the end. Although it's not necessary, again, I agree absolutely with Michelle.
Okay, thank you. I'm going to proceed. So the patient also had a CT of his chest, and you can see marked in red that there were several solid pulmonary nodules on both sides, and they were called suspicious. So this is one area, and then there's a very small on the left side. The biopsy came back, high-grade sarcoma with lipoblasts, well compatible with pleomorphic liposarcoma, and a G2 tumor. I'm going to show some slides. I don't know, Beata, you haven't seen them, but I don't know, is this obvious diagnosis?
Well, I can see some lipoblasts in there, and if DM2 is negative, that's obviously diagnostic for this tumor. And well, the only comment is at least a G2, of course, with this size. So I never state, like G2 definitely, but at least a G2, but high grade.
So how would you report it?
I would report a core biopsy with pleomorphic liposarcoma, at least G2 high grade.
Okay. Because this might also be relevant when you use a tool, which I'm going to ask later on, and then you have to type in something. So you have to make a decision which number you type in. I guess this is just more of the same, or any other aspects?
Yeah, just pleomorphic high-grade sarcoma and the diagnostic feature are the lipoblast, which are here in a close-up.
Okay, thank you. So next question, how do you want to proceed? Obviously, primary resection is one option, preoperative radiotherapy, preoperative chemotherapy, or 2 and 3, so radiotherapy and chemotherapy, and then obviously the sequence question would come up.
Christian, how old was the patient again? Sorry.
57, and fairly fit.
So young. So
there's now a multiple choice. I think yeah, sorry.
Can you ask the audience now, Eugen? Can you do that?
It just popped up on my screen.
It already is working. We already have more than 30 answers.
Very good. Well, let's say the answer are primary section 25%, preoperative radiation 38%, pre-op chemo 8%, and the sequence 30%.
Okay, good. So pretty much well distributed. So one third, I would say. Good, thank you. Next slide. No, I can't go on. Yeah. So another question is, do you use circulator or PERSARC to make a decision, especially now on probably chemotherapy? Again, do we also have the voting for this?
No, for that we do not have the voting. Sorry for that.
Anybody who wants to comment on circulator or PERSARC use in such a situation?
Maybe let's ask Timo, Michelle, and I can also contribute. Michelle, do you use it?
No.
And why not?
Because it won't change what I'm going to do. You know, this is a high risk. This patient is high risk, and there's no evidence that neoadjuvant chemo is going to help in any way. And perhaps if you use IFOS and DOX post-op, you can prolong life or provide a few % increased survival. But what would I change using anything other than knowing that this patient is a stage 3B high-grade, high-risk sarcoma with no known information regarding metastases? We don't have evidence for metastases at this time. So you're going on the assumption that there are no metastases. So you go ahead with aggressive local control.
Timo, I think you raised your hand for a short moment.
So I also don't use a circulator. So PERSARC, we have to say it's not actually validated or even thought as a tool to do prognosis evaluation. It's more thought about follow-up and the risk of relapse during follow-up. The circulator, although there are data that show that you can guide your treatment with it, I also don't use it. I agree absolutely with Michelle that it doesn't change my decision, first of all. Secondly, the circulator has a very large data set, but this is already very historic data, and a lot of entities are also not adequately depicted in the circulator, so I'm rather wary of using it in the clinical routine. However, I would so there are differences obviously between Europe and North America, but in this case, for a fit patient, I would go for pre-op chemotherapy, because even this few percent that, or at least I would offer it to the patient, telling them that the survival advantage may be around 10% at 5 years if we are good. And we would prefer to do pre-op chemotherapy followed by pre-op radiotherapy. But again, Michelle is absolutely right. Aggressive local control would be the absolute standard.
Okay, thank you. So I just put in the numbers. I alluded to this before, so you have to type in the age of the patient, the grade of the tumor, so it would be, I typed in grade 2, and the patient has a 10-year overall survival of 48%, so he is, as Michelle mentioned, a high-risk patient, and obviously there's this data from Pasquale et al. That these patients might profit from some form of chemotherapy, but this is a post-hoc analysis with all caveats. So we
maybe Christian, in this context, we analyzed 300 sarcoma patients with sarcolateral Persac, and we found that our patient cohort is by more than 10% different.
Mm-hmm.
So this may indicate that we would overtreat the patients, and this is I think it is a problem. It's also interesting that, let's say, the original institutions who contribute to both, one of them is also Toronto, they do not use chemotherapy at all. And they, I mean, you know, officially it's not determined, you know, which survival curves in the original publications belong to which, but it's not that Toronto would be far worse. Another issue is the calibration, how it's done. So that's something, let's say, I cannot comment. This is a statistical aspect. And what is a little bit, what we have to question ourselves is, originally, well, this is a nomogram. And to translate the nomogram into a formula is apparently very tricky. But this formula is not published, so it cannot really reproduce, you know, what we find on the app as opposed to the nomogram. And I think that's why, you know, all these factors may explain that it's maybe not enough, that we need to have more. But I think it's an important step, let's say, at the level of the nomogram, but maybe that's the reason why we have to introduce the ML algorithms in the future.
I mean, I guess what it shows is that these patients, you all agreed on, and I also agree that very good local control is really important for this patient, but patients don't die of the primary tumor usually, but they die of metastases. And I guess that's why this discussion always comes up. How do we prevent metastatic spread early? And I guess this has to be some form of systemic treatment. I'm aware of the not very convincing data that we have, but I guess we can't solve today
Sure.
this issue on who really does chemotherapy and who does not. And I mean, I'm going to proceed with the case, and you'll see that we decided to give chemotherapy. So we decided not to look into the lungs or cut out one of these nodules. We said we don't think it's metastatic disease, but we think that chemotherapy plays a role. So we decided to give him neoadjuvant chemo, planned to do RT and then surgery afterwards. So this is the image before starting chemo. And you can't see it, but the tumor was even much bigger. So it's just a few weeks since the first image, and it's now 28 centimeters in diameter. And I'm going to show you this again. This is the sciatic nerve area, and this hasn't changed since the last image. So there's no obvious infiltration of the sciatic nerve, but the tumor is close to the sciatic nerve. This we also, which we don't really need to, did just a CT scan. This was because there was this discussion about lung metastases or not. You just see the large tumor and that there are no other signs of disease, no obvious other signs of disease. Okay, so we started chemotherapy, and he had the first administration end of May and the second one in the middle of June. Then he was hospitalized for febrile neutropenia, which is a common side effect of this treatment. And then he had an emergency admission just shortly after. He had been left the hospital after his neutropenia because of an increase in pain. and he had another MRI at this moment. The tumor actually looked bigger from the outside, you can now see that there is in this area, you can see that there is more contrast enhancement. The cystic part was bigger, the solid part was smaller, so it had responded to treatment, but the tumor had continued to grow along the sciatic nerve. And this, you can see this again here probably. So, however, contrast medium absorbing soft tissue in and around the adjacent piriformis muscle on the right, including the sacral nerves S1 and S2 running there on the right and knurling of the greater sciatic foramen. So, disease progression in a very unpleasant area. We did a CT scan again of the chest, no change there, so no metastases. So again, how do you want to proceed? Try to resect the tumor anyhow, and if do a hemipelvectomy or do a marginal resection to preserve function. Proceed with radiotherapy now or any other form of treatment.
Hey, Christian, while we're waiting, I would, before making any decision, I would very aggressive about confirming that what we see in the pelvis is tumor. I know that there's contrast enhancement, but you know, could you do a PET? Is there any way to confirm? Because you don't want to make a decision based on what you think might be there as opposed to what you think there.
So you think that there could be inflammation instead of tumor?
Yeah. Because it's very, very unusual for sarcomas to do that. It's very unusual. It can happen, but they tend to grow centripetally instead of infiltrative. And like you can have an infiltrative sarcoma, but this is not a myxofibrosarcoma. It's not behaving like I've seen before. Now that given that being said, we don't use neoadjuvant chemo, so I don't know what happens on chemo. So maybe this is something that happens on chemo. I don't know. But to me, I would want to confirm. And if you can do a PET, I think that's probably the easiest way to do it.
So I agree. This for me, this is very, very uncommon. Even when you see a progression with chemotherapy, which is not frequent, but then you would usually expect that the whole tumor continues to grow and not only the infiltrating aspect. We didn't do a PET, so I can't show the images, but I think that's a good point. So the majority actually would go for preoperative radiotherapy, hemipelvectomy, some marginal resection, nobody with other treatments. We actually presented the patient to also Bruno's tumor board, and I think you were more in favor of doing more aggressive surgery than what we did. So I continue. Schließen. Sorry. We also did an MRI, which I can't really explain the images, but again, there was our radiologist said they think this is the tumor growing along the nerve. Michelle, it's not what you said that you would like to see another functional imaging, but obviously they think there could be tumor. At my institution, the board decided to attempt debulking and then do post-operative radiotherapy to mark the site of R1 resection and not to do external hemipelvectomy due to age of the patient, high morbidity, and the possible, I think this is a bit contradictory to the beginning where we say he doesn't have metastases. But this is what happened. So in July, the tumor was resected. So everybody who doesn't want to see bloody pictures, now close your eyes because you see the surgical site now. And Bruno, you already said what is on the image. Do you want to comment?
Yeah, I guess this is the sciatic nerve here, which is tagged in the yellow ribbon, goes along through the field. And I think that's what we would expect based on the imaging. Just there was one chat in the comment. Was there any bony involvement? Probably not.
No,
right?
no bony involvement. Yeah.
But Kim, who asked the question, maybe you can come into the discussion, and maybe you can, maybe Eugen can bring you into the panel. Then you can talk with us. Eugen, can you do that? But just go ahead otherwise.
Okay, so histology, the resection was performed marginally in Rusana at the histologically examined sites with a narrow intact connective tissue, skeletal and muscle margin. However, as the tumor broke open intraoperatively, no formal statement regarding the R status is possible. And you see that there was some tumor regression. Okay. So how do you want? I know nearly nobody would have done what we did, so it's probably difficult to comment on what to do now. But I guess sometimes you also get referred patients who were treated in other institutions, and you wonder what they did. So what would you do now? Would you do postoperative radiotherapy, follow-up, or other treatments? Okay, a large majority for postoperative radiotherapy. Thank you. That's what we also decided to do radiation, perform radiation. So before the patient started radiation, the radiation oncologist did another MRI, and they discovered this nodule about 3 centimeters. So obviously the tumor had not been resected completely, or had grown already, so not such a good situation. And then the patient, so this was interim, came to the hospital with this image, a very small miliar, small nodules. And the first doctors who saw the patient said, well, he now has widely metastatic disease. I don't think it looks like metastases, and the patient actually had a mycoplasma pneumonia at that point. So what we decided now to do radiation now, and then do a re-resection of this leftover part of the tumor. Bruno, sorry, yeah?
Sorry, I saw Kim among us. Maybe you can comment on the imaging that you saw.
You mean the CT of the chest, or the
both?
Local,
let's say just both. Yeah.
Yeah, indeed. The CT of the chest, I would say, no, it's not typical for lung metastases. It is. It could be some reaction on the chemotherapy. No, he didn't receive. He did receive chemotherapy.
Yes,
could be a reaction on the chemotherapy, or indeed some atypical pneumonia because of the immune suppression. And local, yeah, it's difficult. The local situation. I was thinking, is the SI joint yet? Is the SI joint involved or not? That's why I asked the question. But I think, yes, very untypical, of course, for this tumor to have bony involvement. And this lesion, it's pretty difficult for me to say where it is exactly. If it is indeed in the sciatic nerve. But it's untypical for the tumor indeed to have this progression actually in the depth. So yeah, it's pretty hard actually from only a few images.
Yeah,
sure.
I mean, I took too much time anyhow. So my take home is, so this is, I guess what we still need as a community is define the role of primary chemotherapy in marginally resectable extremities of tissue sarcoma. Looking back, we had this discussion with the surgeons about the complete resection along the sciatic nerve. So I think that's really important that they say, well, it's easy or it's very complicated. What I also think is that there should be retrospective acceptance of the interdisciplinary sarcoma board decision. So not at the end they say, well, the patient has now progressive disease, we should have done it differently anyhow. That's always easy. So I think at each given step, we have, as the sarcoma people at the board, have to take a decision, and hopefully it works out nicely for the patient. In this case, obviously it did not. And then this is for people who do preoperative treatment, have a rescue plan in the event of local progression.
Thank you so much. This is awesome. Maybe, yeah, please.
No, you go ahead.
Maybe, let's say, coming back to Michelle's question, let's say this intrapelvic or this lesion in the notch was confirmed as tumor. How would you have approached it? Maybe I will want to ask also Alexander and Frank and Timo. Maybe you can give your opinion. What would that have changed? Michelle?
Yeah, so if we could confirm that it was intrapelvic at that point in time, I would have gone ahead with a hindquarter amputation, or at least offered it to the patient, because at that point, any other local treatment would fail. So the only local treatment that would be successful or has the possibility of being successful would be hindquarter. And I recognize that that's a very involved, deep, difficult decision to make. But especially in the absence of known pulmonary metastases, but that's sort of where you are at that time, and you have to deal with that situation, and that's the route that I would take at that point in time.
Alexander, would you have done? Are you thinking the same way?
Well, I think I would. I think that's a situation where we don't usually employ chemotherapy for our patients. I do think that this is one of the ones that maybe we would have considered it. I can't remember the patient's age.
57.
57.
57?
Yeah.
Yeah, so I think we might have considered, but our algorithm would usually be chemo, then RT, and then surgery. And I think, that neoadjuvant RT also gives you that opportunity to see if any of those things are declaring, because it can be a little bit nebulous and hard to say on the chemotherapy. But then if you start them on radiation therapy, you've got this, 2-3 month window where things will kind of declare themselves. As for the decision regarding the surgical treatment, I agree with Michelle. It's a tough call. You'd really have to scrutinize all the images to know, where exactly is it extending? I think somebody raised the point about bony invasion. I think that's a really important point as well, obviously. I think the short answer is it depends, right, on what all the imaging shows. We probably would have still gone for a salvage, and probably, but it really, it's a very superficial statement for a much deeper answer based on a multitude of factors.
Awesome. Frank, what would you have done in Mainz, Germany?
Sorry, I was coming late because I was stuck in the OR.
Okay, no problem, no problem.
I only got the take-home message, so sorry.
Okay, no. Well, welcome. Good you have joined. Would anyone do concomitant chemotherapy and radiation pre-op, or staged?
Perhaps if I can make a comment.
Please, Timo.
So it's always not a good idea for a surgeon to be the advocate of chemotherapy, and think Christian is definitely more the better guy to talk about this. But I would say that I'm not really sure we can really talk about progression under chemotherapy, because the images we saw at the beginning, obviously the tumor was smaller, but we saw images before the beginning of a neoadjuvant treatment, and the tumor had already created this space in the intrapelvic region. So for me, the progression took place actually before the initiation of treatment, and that would have been the case regardless of the choice of modality. So that's, I think, a very important message, showing also how necessary it is to do images before you start with neoadjuvant treatment, because in any other case, you wouldn't know what happens. Secondly, regardless of whether we accept that the tumor was progressing or not, I'm personally not a huge fan of operating on patients who have been progressing under systemic chemotherapy. I also believe that these are exactly the patients where we need to achieve a stabilization of the situation before we do surgery. So I also would have probably gone in this case for neoadjuvant radiotherapy, even if the patient was complaining of strong pain. So of course, I don't know the patient, I don't know how the situation was, but I think for me, the switch to neoadjuvant radiotherapy, especially in this marginal resectable case, would be very important. And regarding the choice of surgical treatment, everything was already said. It's very, very, very difficult. I think, again, most likely, depending on the response under neoadjuvant radiotherapy, if the tumor hadn't grown further, if we were able to see at least some capsule building, even in the intrapelvic area with the same size that we saw in the MRI, I think I would have always, obviously, as Michelle said, offered both options to the patient. I would discuss them with him, but I would most likely tend towards the focally marginal resection rather than the amputation, at least after neoadjuvant radiotherapy. That's what we would have done.
Well, this is fantastic, Christian. I really have to congratulate you. I mean, it's awesome that you share this case. I think it's very thought-provoking. There is no single best way, obviously. And I think it's an excellent example how important and exciting it is. We can discuss these things. Again, so many thanks. I understand that you unfortunately need to leave us, but
I'll be back next time.
Thank you so much,
Thank you.
Christian.
Bye-bye.
Let's move on to Bharat.
Thank you, Dr. Bruno, for the kind invitation, and it's really a pleasure and honor to present the case. In fact, I have two cases of a common genre to present. So I come from sort of western coastal region of our country, and these two cases came to me. One came from the south, that is the first one, and the other from the far east of one of these states. So case number 1A was a 33-year-old gentleman who presented with pain over his left gluteal region and thigh of 3 months duration. Clinically, there was no definite lump, but there was marked tenderness that he complained of. So we had a plain radiograph that showed a lytic destructive lesion in the trochanter, and it's kind of multifocal, with including the lytic lesions in the pubis ischium and actually in the intertrochanteric region, and also the acetabulum. So this was kind of a multifocal scenario of lytic destructive lesions, primarily in the bones. And contrast enhanced MRI showed heterogeneously enhancing lytic expansile lesion in the left ischial tuberosity extending into left acetabulum, with similar lytic lesions in the upper shaft of the left femoral intertrochanteric region. These lesions were PET avid, and there was also cutaneous thickening and subcutaneous fat spreading in the left inferior gluteal region. So the impression on plain radiograph was metastasis and Langerhans cell histiocytosis, considering multiple lesions in the bone. And these are a couple of images of the MRI post-contrast enhanced multiple lesions that you can see here. So then there was a biopsy from the greater trochanteric lesion. You can see woven bone and a couple of these multinucleate giant cells scattered, and a population of oval to spindle cells. So this is more like the woven bone, the pink, and you see some scattered multinucleate giant cells, and then the oval to spindle shaped cells. Higher magnification, you can see these multinucleate osteoclast-like giant cells, and then sort of these oval cells with some spindle cells. And then there was the gluteal biopsy, which you can see the epidermis and a lot of this sort of spindle cell proliferation with this focal ulceration. Higher magnification showing you this collagen and this sort of infiltrating over to spindle cells all across. In addition, the patient had a lesion in the ileocecal region, and that was granulomatous inflammation, which was of tubercular etiology. So there were lesions in the bones, and there was a granulomatous inflammation, of tubercular etiology in the ileocecal region. And that's case number B that came to me from the Far East about a couple of years back in this young engineer, aspirant engineer, who had this multiple lesions in the skin, which were nodular over his left shin. So you can see the lesions on MRI and also on the axial view with this cutaneous to subcutaneous lesions, couple of multiple lesions, very concerning clinically. And the biopsy, not a very good slide, but you can see spindle cell proliferation below the epidermis. And if you see on higher magnification for these type of cells, you see elongate tadpole-shaped or racket-shaped cells, as we call them, which resemble the rhabdomyoblastic cells. And on the other side, you can see the same lesion showing more sort of polygonal to epithelioid cells, which resemble or appear like you see in this very sheeted manner in an epithelioid sarcoma. So all in all, there were plump spindle cells with moderate to abundant cytoplasm, very characteristic, which look very rhabdoid, and there were some scattered inflammatory cells. The referring diagnosis in this case, understandably, because you have these very elongate rhabdoid cells, and this was in 2016 that case came to me, was, a diagnosis offered was rhabdomyosarcoma. And the plan, given the multiple lesions in this young patient, was a chemotherapy on the lines of rhabdomyosarcoma, followed by a major resection, considering that there were multiple lesions. So I have a question here. How would, in pathology, one would proceed in these scenarios of two interesting, challenging cases? Morphological diagnosis only. We proceed with immunohistochemical staining, a good friend and support. Go further for molecular testing, and presently, as we have next generation sequencing or the NGS. So depending upon which part of the world with certain resources one is, there could be a variation in the choices. I can understand, and let's see how the poll shows up. So a vast majority, 61% feel immunohistochemical staining they would go for. I'm very interested to know for morphological diagnosis in 3% cases, a bit of an adventure, I feel. Molecular testing in 21% and NGS in 16%. So while we do feel a sarcoma panel in NGS gives you a choice for identifying certain translocation related or specific, mutation-based sarcomas, which characterize a lot of tumors that we know. And so, of course, in this case as well. So, like it was being seen, we proceeded with immunohistochemical staining. And when we look at tumors like this, these are the list of differential diagnoses that come to mind. So a leiomyosarcoma expresses desmin and HCAL-desmon. A spindle cell rhabdomyosarcoma, very close, or maybe, a closest to mimic, or this could be one of the two, would show a variable desmin positivity. They might be desmin shy, but mostly express myogenin and myoD1, especially the sclerosing, which are diffusely myoD1 positive. Epithelioid sarcomas show consistently epithelial markers like pankeratin, EMA, maybe CD34 in about 60% cases, and consistently loss of INI1 or SMART-B1. We have a marker for MPNST, apart from S100 that we were utilizing earlier, is SOX10. And now a good number of MPNSTs, especially the radiation-induced, show this loss of H327Me3 histone as a result of SUS12 mutations. Well, then in bone, if these lesions occur that I showed you in for case first, one would consider perhaps a metastatic carcinoma, a sarcomatoid type, which will show or variably express epithelial markers along with certain site-specific markers, for example, the PAC-8 for renal cell carcinoma, which can metastasize and have a sarcomatoid subtype. A giant cell tumor of bone, because you can see, and you saw giant cells in case number 1, and of course, multicentric we can see, and we have the magic marker, the histone 3.3 G34W for giant cell tumors, just like we have for chondroblastomas, the K36M. So like I mentioned, in case number 2, the referring diagnosis were rhabdomyosarcoma. And then with a couple of thoughts for the cases, that's case number 1, we proceeded with a pan-keratin because there were multiple lesions just to make sure or feel that, could metastasis be one of the possibilities? And we threw in A1A3, which is kind of very focal positive. You can see occasional cells and you can see the control, the overlying epidermis. It's nicely positive. We proceeded further with CK7 with a thought perhaps we're dealing with some sort of sarcomatoid carcinoma, and that was focally, again, positive, but very distinctly positive. So this tumor is spindle cell and showing epithelial marker differentiation, and the scenario is multifocal. We went ahead with, other thoughts of another entity, which I'm coming towards, and we did a CD31 that is an endothelial marker, and you can see the blood vessels nicely highlighted, and all these tumor cells were diffusely positive for CD31. So this is a vascular marker, an endothelial marker in this context that we utilize. And further, ERG, the ETS transcription factors, again, another off-late, relatively new endothelial marker, and that's nicely highlighted all the cells you can see across. And of course, the other usual suspects like epithelioid sarcoma was ruled out with lack of INI1, CD34, and of course it was EMA negative. So Desmond ruled out a possibility of a rhabdomyosarcoma, including spindle cell type, and off late we're trying to identify ALK-positive spindle cell tumors in bone and soft tissue. So this was negative for ALK as well. So the diagnosis here was pseudomyogenic hemangioendothelioma, which is an intermediate malignant tumor, between the benign and the malignant, and it mimics, like I mentioned, high-grade sarcomas like rhabdomyosarcoma and epithelioid sarcoma. And this was case number B that I showed you in that young patient. The slides are not very good because this was a 2016, slides, and again, A1A3, the pan-keratin is positive. Considering this was positive for A1A3, we wanted to make sure that we're not missing out on an epithelioid sarcoma, and INI1 is diffusely retained, which was also in the case number, the first case as well. So FLI1 is another good surrogate, a vascular marker, not very, perfect, but just like ERG, ERG is a better one. So we utilized FLI1, and of course, CD31 was positive. So this was also a pseudomyogenic hemangioendothelioma, an intermediate malignant tumor which can recur but rarely metastasize. So we were able to salvage with these lesions that were excised, and this is a graft. And then the patient had recurrences on his toe, and again, given that there were multiple lesions, there was the disarticulation performed, and you can see these multiple lesions. Just like we saw, in the original, you can see these very plump epithelioid cells with these inflammatory cells. But even though they look a little atypical, we didn't see any mitosis or any tumor necrosis in any of these lesions, and also in case number 1. So coming to this bit of a story about pseudomyogenic hemangioendothelioma in 2003, Dr. Falk and Billings described epithelioid sarcoma, a entity which mimics or can be misdiagnosed as epithelioid sarcoma, occurs in distal extremities, characterized with multifocality. Just like I shared with you these cases, especially the case number 1, unusually in bone, and composed of epithelioid spindle cells with endothelial differentiation and co-expression of epithelial markers. In 2008, Dr. Hornick had similar observations, and he published 50 cases, 50 such tumors in 2011, and designated this as pseudomyogenic hemangioendothelioma, which is actually an epithelioid sarcoma-like, but not. So we don't use this term epithelioid sarcoma-like, and it's now a pseudomyogenic hemangioendothelioma in the recent WHO classification. So vast majority of these lesions are subcutaneous, and 50% can be intramuscular, and 20% present with lytic bone lesions, as I showed in case number 1. So soon it was identified as multifocal in soft tissues. It also was identified in bony sites, including in 2013 with 5 cases from the Stanmore group, and then there were subsequently in 2016 about 10 cases. In 2020, in a large series from the Italian group, they identified 24 cases of pseudomyogenic meningoendothelioma involving the bone. And as tumors evolve, their genetic motifs or the underlying signatures also. So in 2014, a characteristic translocation 719 leading to formation of this specific fusion, SERPINE1 FOSB, was identified, leading to the upregulation of FOSB in these tumors. And then the molecular spectrum expanded with another study, another demonstration by the Sloan group from Dr. Narasimhagram, who demonstrated another ACTB FOSB fusion, which is kind of a promoter swapping, underlying some of these tumors, which perhaps are more solitary than multifocal. And then there's been another description of the WWTR FOSB fusion gene. So these kind of lead to the overexpression of FOSB as the marker that evolved. And that was our experience in 2000 and years before. We had like 5 cases of these tumors in the bone. And that was one interesting case that we came across, again, multifocal in the lower end of the femur and the upper end of tibia in this young boy, mostly metaphyseal to epiphyseal, a very characteristic spinal cell morphology with lump cells. And intriguingly, this tumor was negative for pan-keratin. And then CK7 was tested, it was positive. So this just goes to show that even though the vast majority of these tumors show epithelial markers like A1, A3, so some of them can be less positive and they can be variably positive. So we go further with certain other keratins to test, the epithelial differentiation. And of course, you have the vascular markers like ERG, which is very sufficiently or diffusely positive in most cases. So like I mentioned, the fusion gene led to identification of FOSB as a useful diagnostic marker that we have now in 96% cases of pseudomyogenic meningoendotheliomas and also in 54% cases of epithelial hemangiomas. This marker is positively expressed. It's a nuclear marker. And in this particular case, it was positive and it was tested in Dr. Andrew Falb's lab at Mayo. So you can see diffuse expression of this marker, even though epithelial marker was A1, A3 was negative, and it was positive for CK7. So we've been studying and kind of sharing our experience with these tumors, and this particular case occurred in the scapula, a large lytic destructive lesion again in the bone. A very typical morphology of these plump spindle cells, abundant eosinophilic cytoplasm, inflammatory cells scattered throughout, low in mitosis, maybe occasional multinucleate giant cell. When in bone, one starts to wonder, perhaps you're dealing with a giant cell tumor of bone. So again, the immunoprofile, you can see very typical, diffusely A1, A3 positivity, FLI1 positive, INI1 is retained, which is lost in epithelial sarcomas, or the SMARC-A4, the other SWE/SNF protein. That's another case we came across in the finger, and the differentials on imaging were metastasis versus a giant cell tumor. And you can see a similar morphology of these plump spindle cells, characteristic of pseudomyogenic meningoendothelioma, CD31 vascular marker positive. These don't show CD34 in most cases, unlike the epithelial hemangioendotheliomas, which do show. So CD31 and are consistently positive in a lot of cases. And even though they look a bit atypical, you can see the proliferation is low and they were very low in mitosis. So I come from, this part of the world, we have sometimes needle preceding the scalpel, and these lesions are superficial, and these get effeminate. In this particular case, was referred as a myxoinflammatory fibroblastic sarcoma. And just to share with you cytomorphological spectrum, looking at these cells more closely, very epithelial, the same way we have this plump spindle to polygonal cell forms. It can be very difficult and challenging. It's a very rare case I came across. And there was a simultaneous biopsy, very typical of pseudomyogenic hemangioma. The most closest differential in this case, considering these superficial lesions, was an epithelioid sarcoma, and INI1 and SMARCA4 both were retained in this case, and this was another multifocal pseudomyogenic hemangioma. We've also come across a case in head neck region in this young 21 years old male who had these multiple lesions over the scalp. My colleague in head neck came across and shared this case. And you can see this. So these lesions are multifocal, but they are not very large size, about 1 to 2 centimeters size tumor mostly. And these are PET avid. You can see in this particular case, similar morphology, abundant cytoplasm, and classic immunohistochemical profile of co-expression of epithelial markers, vascular markers, and retained INI1 expression. And the usual suspects like rhabdomyosarcoma ruled out with desmin, myogenin, MyoT1, and of course, CD34 negativity. So this particular case was actually referred with the diagnosis of leiomyosarcoma, and we tested for SMA, which was focal, and desmin, which was completely negative. So we see these tumors very rarely in the head neck, and this was like 12 cases in the literature, to our knowledge, published in the head neck region. How do these tumors behave? Mostly they are dealt with surgical resection, including the cases that I shared with you. This particular case in the head neck location was disease-free post-wide excision. That is the preferred treatment with 8 months disease-free interval. The cases that I began with, 1 and 2, again, the first patient was recommended surgical excision. However, he refused and is alive with disease. I called yesterday, and that's 18 months duration with reduction in symptoms, lesions. The area is not very tender, as he says. He's on the anti-tubercular treatment. It's not taken any further treatment. Is kind of alive with disease. Patient B had an excision for even the recurrent lesions and is disease-free, 16 months till the last follow-up. So the challenge can be, while managing these cases that we've seen over the years now, whenever they are multifocal, which happens in 60% cases, especially in bone lesions, and these can be very concerning on imaging and also have persistent symptoms in patients. So there's some, alternative or the other therapies, coming up on the horizon to inhibit the bone destruction. Denosumab is being considered, which is utilized in giant cell tumor of bone for having better resection, So it's kind of believed to be a magic bullet for giant cell tumor of bone. So I think everybody knows that these are for having better resections for those large recurrent giant cell tumors. So the same, thought to have, inhibit the destruction of the lysis that this tumor leads to. So denosumab has been tried. That's another teletitinib that I could come across as a targeted therapy. And off late, the sirolimus is being tried. Targeting this fusion. That's been also seen in a couple of cases in the Italian group who were triaged for, the mTOR inhibitors, because this fusion, can be targeted with the mTOR, the PIK3 AKT mTOR pathway. So to wrap up my case, pseudomyogenic hemangioma can be misdiagnosed as sarcoma, carcinoma, and giant cell tumor. It's kind of a pitfall, and the way to diagnose accurately is to know about it. Maybe in the past, we've all made mistakes earlier when the entity was not known, but we've learned and we're cautious. It's crucial to have an index of suspicion, especially in clinical settings, multifocal lesions, young patients in bone, and make an appropriate choice for immunohistochemical stains, including FOSB, that is a good new age marker for their exact diagnosis. The challenges with multifocal lesions, especially in bones, and perhaps targeted therapies in those cases might be interesting to explore. But I'd be happy to learn from the audience and the panelists here for any further therapies in this scenario. So thank you so much, and I'll be happy to have questions and comments.
Bharat, thank you so much. It is really impressive, and you moved our understanding again a level up. I'm always fascinated by you pathologists, how you help the clinicians to open the doors. As you nicely showed, pathology is not just a report, there is so much more behind. And I think that's alone already a great value of your contribution. I saw that unfortunately Sebastian had to leave, but Beata, do you want to comment from your perspective? And
yeah, Bharat, thank you very much for those very nice cases. It's really impressive. I have one remark concerning the differential diagnosis, which I was wondering, perhaps in your area the differential diagnosis is different. But if I'm as a pathologist concerned with the multiple spindle cell malignant lesion concerning bone, soft tissue, and so on, so quite top the list of the differential diagnosis would always be melanoma. And you haven't noticed it, and that's kind of that would be top, but this is perhaps I don't know if there is Caucasian differential diagnosis preference or what's your comment on this and this point, and then other differential diagnoses like Kaposi or angiosarcoma, you definitely rule those also out, and I wouldn't kind of stick to cytokeratin positivity. It's maybe misleading. So I think, as you mentioned, that this supposed to be immunohistochemistry is so helpful and get you far at the differential diagnosis much faster than NGS or any molecular testing in this context.
Yeah, I completely agree. And I think, our choices for differentials can be in which part of the world. So, and so the choices of our tests. But I agree that, immunohistochemistry is really good. And the way FOSB has come up, it's, I think, one of the good magic markers. But again, depending upon the feasibility in different scenarios, I do believe that, when you have multiple lesions and melanoma can appear in any forms, spindle, pleomorphic, epithelial. I pay a detail towards the prominent nucleoli inclusions, but they can be without that as well. So I completely take your point. It's just that we start with an epithelial marker and they might show positivity, and then sort of our thought process rolls towards, carcinoma and then this entity. In fact, angiosarcoma is absolutely another very close overlapping differential diagnosis towards these lesions, and then it's just that you see these plump cells, but they are very pleomorphic, and you don't see that anaplasia, and of course they are less in mitosis. So that's one of the kind of clues that it puts me. But FOSB is a great marker. I think that's a choice one can go for. So thank you so much for it, Dr. Beata.
Very interesting.
Maybe other questions for the clinicians, or maybe just for Kim too. Based on the results that Bharat presented, that 60% are multifocal, do we have to stage more closely these patients? Maybe also in the follow-up? Only locally, or maybe what are your thoughts?
Yes, I was thinking about, do I really see a difference in imaging with this epithelial with hemangioendotheliomas versus the pseudo-myogenic tumors? I've seen more of the epithelial with hemangioendotheliomas, and I was just looking through some cases that we have here in the hospital, and we do local imaging, and we know, of course, it's multifocal. It can be multifocal in an extremity, but I don't think we do any PET-CT imaging. As far as I can look back, we only Yeah, here's one case you could consider because they are highly FTG active. So in the case for the bone, you can of course do the PET-CT imaging, and I think for the soft tissue tumors, it should be seen clinically in the skin.
Yeah, yeah, very good. Any other comments from the panelists? There was a question in the chat. Is CD34 negative most of the cases?
Yeah, so unlike epithelial hemangioendotheliomas, which show 34 positivity, and in fact, epithelial sarcomas, they show CD34 positivity in about 60 to 70% cases. So these tumors, don't generally show. They show ERG, FLY1, CD31 as the endothelial markers instead of CD34. I haven't seen, Dr. Beata, what is your experience in terms of CD34?
Yeah, so many of the entities of endothelial tumors kind of do not express all markers consistently. So sometimes, and CD34 is quite often lacking in those specific entities. So that's also my experience. This is such a rare entity, and I've seen only a couple of the cases of those type, and it's always a question for oncologists. That's what you alluded to, those therapies, especially if they're multifocal. So I don't know if the oncologists are also around. It would be, as you mentioned, interesting how they see. But
yeah, so that was my actually question. Thank you for putting it, because that's been our challenge. We've come across now, a couple of cases which are multifocal, because we are the referral center. So patients do present with more than one lesion, and what to do. They've tried denosumab in one case to restrict, the lysis or the destruction caused by the tumor, but we haven't tried the targeted. So I was interested to know, any experience about these targets or anything additional in multifocal scenario. Yeah.
But it's also very interesting, the case you mentioned that the patient kind of refused the therapy. So it's also kind of interesting follow-up on a kind of untreated tumor. So, yeah.
Okay, well, thank you so much. I really appreciate great contribution. And let's go to the last, but for sure not least case, Michelle. May I hand it over to you, please?
Okay, so this is a case that I chose because one, it's very interesting. It's not much of a dilemma with respect to the diagnosis, but it's an interesting surgical discussion. Plus, also it has long-term follow-up. So I think that is something that we don't often have. So, okay, so this is a 7-year-old male. He has a tumor in the right femur. So he has an interesting history. He had a buccal rhabdomyosarcoma and telangiectatic osteosarcoma of the dens. And he has it, so we've radiographically and physically identified a tumor in the right thigh, femur area, but all staging shows no metastases. So this is an isolated situation. So the MRI, this is the coronal stir and axial stir. So this isn't really much of a dilemma. Maybe we could talk about what would you do next, but he had a biopsy and this is the pathology. So should we have the pathologist comment?
Well, this is very well compatible with osteosarcoma, osteoblastic high-grade osteosarcoma.
Right, okay. So that is the situation. So he is 7 years old. He's had 2 previous sarcomas, and he has this imaging. So we need to move forward. What would be the treatment paradigm at your institution? So you can start with chemo, pre or post, and or both. And what regimen would you use? He's had 2 previous sarcomas, but he has not had standard osteosarcoma chemo prior, but he did have a buccal rhabdo with treated with BDCIE. And are you considering radiation? So, Bruno, is this something that we're voting on?
I don't know whether Eugen prepared the slides. Eugen, can you comment on that? I don't hear. Maybe I have another suggestion. This Eva Koszelniak is also among us. Would
Okay.
you mind, let's say, to open up your speakers, then we can comment on that. I think it would be highly interesting to hear you. But of course, if you cannot, then that's all fine. Any comments from the panel? Christian unfortunately had to leave us.
Devo has a question, comment. Frank?
Yes, please go ahead.
Was asking myself whether at some point, at least at the second sarcoma diagnosis, the osteosarcoma diagnosis, there was any testing for genetic predisposition syndromes, because that would be interesting to know whether the patient has anything that would impact the decision for chemotherapy. And then do you happen to know?
Yeah, no, so at that time, the mother, we did discuss assessing P53 status. The parents refused. They just, they were getting pretty, toxified by having to deal with all these sarcomas. They did not want to know. There was no family history. Later on, years later, the family was assessed for Li-Fraumeni and he was positive. But at this time, they refused genetic testing.
Just another question, just out of curiosity. So the dense sarcoma was an osteosarcoma, do I remember this correctly, or was it another sort of sarcoma?
They were separate. They were two. Like, so the dense was when he was, the buccal sarcoma, he was almost a baby, probably a toddler. And the dense sarcoma was maybe a couple years later. So they were separate incidences.
Yeah, I would also go in the same direction as Dimos already mentioned, that is probably some genetic background on this patient. And but I think since we know that patients with Li-Fraumeni will have benefits, even if they have like a lot of chemotherapy, if you go ahead and treat them like a normal osteosarcoma patient, but spare any radiation, because that will probably cause more harm than actually do any good.
Right. Okay. So he had neoadjuvant methotrexate, Adriamycin, cisplatin, and he had a good clinical response, decreased pain. And so then he was ready for chemo. So we opted for neoadjuvant chemo and then to reassess postoperatively. And so we, go ahead. He's 7 years old, very, very young. And we're thinking about surgical resection. What are we going to do? Particularly with respect, there's resection, but then there's obviously reconstruction. So we need to get a tumor-free margin, provide and hopefully any further.
Eva is among us. Maybe we cannot hear you very well.
Me?
No. We hear Michelle. We hear you very well, but Eva.
Okay, good. Yeah.
Okay,
I cannot.
Now we hear you.
Okay. Unfortunately, I missed. I was a few seconds away, and I missed the histopathological diagnosis of this tumor, the last tumor. So I don't know. Was it? What is it?
Osteosarcoma, high-grade osteoblastic osteosarcoma.
Osteosarcoma. Okay.
Yes.
Okay. And nothing with rhabdomyosarcoma. It was not a relapse of rhabdomyosarcoma. Okay.
No. These are 3 separate events: a telangiectatic osteosarcoma, a buccal rhabdo, and now a new standard run-of-the-mill high-grade osteosarcoma.
Osteosarcoma. Okay. And now what is the question?
What would your surgical approach be?
Well, first, no, Eva is one of the prominent peds oncologists in Europe.
Sorry, yeah, okay.
And I think it would be very interesting to hear, let's say, her thoughts on the first question regarding chemotherapy and approach.
Yes,
maybe you want to
Of course, for osteosarcoma, I think that it is the quite, for me, standard procedure to make a neoadjuvant chemotherapy for osteosarcoma.
And despite her regimen that the patient had as a toddler for the buccal rhabdomyosarcoma?
yes, even if you know, you have to regard the cumulative dose of cytostatics, but still, I think in the situation you have a osteosarcoma tumor. It's more or less even in a relapse situation is a chemotherapy is of significance. So I will proceed with chemotherapy.
Very good. Thank you so much, Eva.
No, you're welcome.
Good. So that is what we did. So that's perfect. And okay, so we're talking about surgical approach because that would be the next step. So what needs to be resected? Pretty much the entire femur, the anterior compartment, some medial abductors as well. So this was the tumor was circumferential, had a circumferential soft tissue mass, and it was the vast majority, the extent of the femur, plus some extensive soft tissue involvement. So what, you know, the surgical approach in a 7-year-old it's not a slam dunk, it's not straightforward, but there's lots of good discussion. So what would be your approach for the orthopedic oncologist?
Alexander or Frank, what are your thoughts? Dimo?
Yeah, I think for a young patient like this, they've got a lot of growth potential. You were saying, Michelle, it looks like it extends most of the way down the femur, right? So not a lot of bone to preserve, but this may be one that'd be a good for like a kind of rotation plasty type procedure at that age. I think they could do really well with it, you know, and essentially transpose that up and create a new hip joint out of their knee.
Okay.
Yeah,
I like that idea.
Yeah, I would agree because you will lose a lot of muscle, even bone. So if you try to do an intercalary resection and do a biological reconstruction, probably won't work very good because you don't have a lot of muscle to cover all this, and the function will be really diminished. So probably rotation plasty would be the best, and you can really get good clear margins if you do like the rotation plasty amputation, and then it's probably the easiest or the best functional and the best oncological result you can get in this kind of tumor and growth. Yeah.
Yeah, and I can't tell is the how far up approximately does it go? Does it involve most of your inner throat?
Yeah, neck, inner throat. It's the whole thing. But you can't.
Yeah, I mean, I think intercalary would be the only other thought, but with that, I would go rotation plasty.
Right. Right. The thing about intercalary is, you know, what do you put in the middle? And you can do a Campanacci, like, you know, like a vascularized fibula with allograft. But so this guy's 7. He's had, you know, it's his 3rd cancer. Really, my goal is to make sure that he had 1 surgery and that's it. And that, you know, to get him back to some sort of life that he would, who knows how long he's going to live with that kind of, you know, genetics. So, okay. Is Dimo still on? No? Okay. So yeah, what would you do? So it sounds like we are all pretty much in agreement. There's lots of different options. As you know, you could do hip dysartic, but that's, you know, we don't really have to because there are other options where you can save part of the limb. Extend allograft, especially in a young child like that, you know, he's so much growth potential, and allografts generally fail anyways. So you would just be buying him a lot more surgeries. The option of an expanding prosthesis was thrown around, and I especially at that time, but even now, the failure rates of these are really, really bad, are really high. And especially in somebody that young, he would have significantly more growth that would need to be adjusted. So at this time, I really felt that the best thing would be a rotation plasty. But these are, so you could do resection allograft. We talked about that. This is, you know, this would have an issue with the femoral head viability, but also failure of the allograft. And this, you know, this would be an option. It was in the cards, but it's not something that I like to do. I think allografts are generally failures overall. And he is so young, and so I already explained that. So this just explains how I obviously don't really like allograft. Fracture and non-union infection are pretty much the outcome for at least half. So you're going into a battle that you know you're going to lose. Expandable prostheses. These are great because it could be just one surgery, but then, especially with these magnetic extenders, but he would need quite a bit more of growth and have a risk for the implant loosening fairly early on. So Van Ness rotationplasty, for those of you who are not surgeons, is a fairly old procedure. And what it means is you resect what is affected, and then whatever's left, you turn around 180 degrees. And so you create a new knee joint. The goal is to create a new knee joint. So it's been around for almost 100 years and was developed in Germany, Europe. And so what's the advantage? It's biologic. So you're using the patient's tissue. Because you're creating a knee, instead of having an above knee amputation, you're creating a knee that has really good tolerance for the prosthesis. And they keep their foot with normal proprioception and sensation. And they actually do better with respect to their function than an amputation. Even though this is a kind of an amputation, it functions better. And a brilliant researcher named Bruno Fuchs published that in 2003. So this was in Clinical Orthopedics Related Research. There were remarkably 7 patients. These are rare procedures to do because generally we do them in kids that are under age 10. So overall, their function is very close to an able-bodied population, which is truly remarkable given the situation that you're given with this child. So the problem is it looks weird because you're turning the foot around 180 degrees and it looks strange. It looks weird. So for this patient, these kind of things, when discussing it with the family, to them, you can say, well, I can do an allograft or an endoprosthesis and the leg on the surface will look normal. That is a good sell, but if they need to understand that the long-term outcome with respect to multiple surgeries and eventual need for maybe even an amputation with failures of whatever you're going to try to do to reconstruct, that would be something that they don't think about right away. They want the leg to look normal. So often discussing with families that have, or patients or families that have had a Van Ness rotationplasty will go a long way in convincing them that this is the right surgery. So there are various types, and it's based on how much do you need to resect. And whatever is left that's viable, you rotate 180 degrees. So the type B3A hip rotationplasty was described in 2000 or later, because this is pretty extreme. It's in a total excision of the femur, but the tibia is rotated. The entire remaining leg is rotated, and the tibia then is inserted into the acetabulum to become a new hip joint. And then the foot is now the knee joint. And so this is a technique. It's actually, from an orthopedic oncology resection standpoint, fairly straightforward because it's really just 2 joint disarticulations. It's a hip disarticulation and a knee disarticulation, with careful planning, of course, of the skin flaps, as well as very careful dissection of the sciatic nerve and the femoral vessels, the vessels will be reanastomosed. The sciatic nerve cannot be reanastomosed. You have to actually keep it in continuity because transection of the sciatic nerve is unlikely to recover. So again, there's a hip disarticulation, knee disarticulation. And this is what the leg looks like. There's some soft tissue reattachments that are important for stability. And you can see, again, it's an awkward looking leg. It doesn't, it's something that's going to take a long time for the patient and their family to get used to. But the prosthetic fitting is very compatible with almost normal walking. And, this is a bit extreme. Can the kid jump, hurdles? Maybe, but it gives them a chance to be athletic and to have a functional knee joint as well as a hip joint. So how does this happen? The cartilage in children and bone is very plastic. It can respond to forces and actually reshape itself. So these are extreme examples of the tibia. This is not from my patient, but you can see in the top right and bottom left that the tibia almost looks like a femur, a femoral head, based on its responding to the forces within the acetabulum. And on the right is a normal hip joint. So this, when I was deciding what to do, is actually very early in my career. This is 2009. Can whoever is not muted, can you please mute? Okay, Frank, I think it's you. Thank you. Okay, so so that's what we decided to do. This is the surgical procedure. And again, we outlined the skin as we did, as you can see in the paper. This is the beginning of the hip disarticulation. Very careful dissection of the vessels. Femoral nerve. This is the gluteus maximus and abductors. And you can see that we've protected the vessels, the femoral vessels at the hip joint. And also tagged the sciatic nerve, which requires dissection all the way down the leg. And then we started the knee disarticulation. This is finding the vessels posteriorly behind the knee joint and carefully protecting those. And also the nerve at the knee joint has been identified. Then you need to dissect the nerve all the way up through the specimen. And if there, at this point, we decide there's no sciatic nerve involvement in the tumor. Otherwise, this wouldn't be a possibility. This is a specimen. It is the femur in its entirety with the surrounding musculature of the thigh. And you can see the sciatic nerve has been protected and dissected. The vessels have been transected. But this now becomes a free flap so that we turn the leg around and begin some soft tissue. You want to have, prior to vessel reconstruction or reanastomosis, you need fairly good soft tissue stability. Otherwise, the reconstruction or anastomosis will be flown around in the wound and it won't be stable. So we started with soft tissue reconstruction, attaching the tibial, basically the knee capsule, back to what is remaining of the hip capsule and the surrounding muscles. And that's what we're doing there. And then the plastic surgeons came in and did a vascular anastomosis. And then further repair of the soft tissues, some of the more soft tissues, skin, and closure. And that was the final product. There is a need for immobilization, so the patient was placed in a spica cast. If there was another option, I probably should have done that, maybe a splint of some sort or an abduction brace, because the spica cast is probably the worst part of the procedure for him. So this is the initial post-op x-rays. You can see that the tibia is reapproximated to the acetabulum, and there are lots of vessel clips. This is initial post-op imaging and initial post-op imaging. He is not, there's been no weight bearing at this point. That's why that he's not, the tibia is not really sitting well in the acetabulum. It's with the soft tissue reattachments, you need to really get that scarred in and then allow the patient to weight bear. This is him in initial rehab with this prosthesis. And then he progressed to a cane and then did not require any aids. So you can see from the date stamp, it's 2009. So the family decided they declined adjuvant chemotherapy. They sort of had enough and decided not to go with any further chemotherapy. The response, the tumor response rate was excellent. It was over 95%. So this is him at 5 years. This is the MRI. Does he have a new hip joint like we saw in the academic papers? Not really, but it's not bad. And he walks independently with his prosthesis. He never had another surgery. He had one surgery from the time I knew him on his thigh. So we operated when he was 7. And he is now almost 16 years post-op. He's never had any other surgeries to deal with any post-operative complications. He graduated from McMaster University, has a degree in marketing and media. So this is a happier ending, but actually he's never developed any other sarcomas, which I find absolutely amazing.
Michelle, thanks so much. That's
Bruno wanted me
really impressive. Go ahead.
This is more of a show and tell. Bruno, you wanted me to have some questions?
I think we can just have an open discussion on this. I just think it's very, very impressive. But let's ask the colleagues whether they have questions, specific questions.
I think that looks awesome, Michelle. My only question is, did you have any consideration to save the full knee joint and then fuse, what's remnant of the distal femur to kind of create both a hip and a knee joint?
Wait a minute. So you'd have so it saves some distal femur.
Yep.
And then do some osteosynthesis to the pelvis.
Correct. Yep.
I looked at the different options for rotationplasty, and I did not think of that because I love the idea of creating a new hip joint that was biologic as opposed to with any osteosynthesis, which can fail. And he was only 7. He's, you can tell from the pictures, he was only 7, but he's not a slight kid, he's obese. There was a lot of weight-bearing issues. I didn't actually think of that. And, to tell you the truth, like in 2009, I was very early in my career. My clinical partner had died suddenly. He was my senior partner. So I didn't have a lot I didn't have really anybody to direct me on this case. And I trained in Toronto. They don't do pediatrics, so I didn't do any pediatric training. So I had to sort of go to the literature, really. And I found that this like 3BA, was very intriguing in that it was biologic and there was no need for any bone to heal or any osteosynthesis to not fail. I think that's a good idea, and it could have been an option, but I didn't seem like it was the most biologic approach that was going to limit his risk for.
But Alexander, you would fuse the distal femur into the acetabulum, right?
Yeah, I think those would be I think what you have there is totally reasonable and looks great, and they've obviously had a really good outcome. I think those are the 2 described methods: is you either try and put the tibia into the hip joint, or if you can preserve some distal femur, you can fuse the distal femur into the acetabulum, and then you've got preserved knee function and preserved ankle function.
Yeah, I think I have a picture of all the different options that.
Michelle, how did you fix the tibia into the acetabulum? Did you fuse, let's say, suture the cruciate ligament to the ligamentum capitis femoris? And could you control for the rotation?
Yeah, so we reattached the tibia, like the capsule, the knee capsule, into the remaining capsule of the hip, and the remaining abductors to the, I guess, the tibialis anterior. Basically took the remaining tendons and ligaments around the knee, and not the ACL. We didn't use the ACL or the cruciates. What was really critical was the post-operative immobilization to allow that to scar in. And once he scarred in, he could. It wasn't a very stable joint, but he was able to use the prosthesis without any concern for rotational instability. But I can see like what Alex is saying, that for the bottom right, the bottom images, you can fuse to the pelvis. Yes. Yeah, but those 3 screws, they better work.
May I have?
Please, Eva.
I would like to support your decision, because we, as you said, the rotationplasty looks terrible, but from the functionality is much better than all limb preserving operations, and especially in such a young child. It was a good decision. I had 2 patients like this, one with Ewing and one with also sarcoma also, and the children, such a young children, they adapt very good to this kind of operation. And even if, as I said, it looks terrible, and sometimes in older children it is not possible to convince the patient and the parents for this operation. But as you also said, they have almost no complication, and the majority of limb preserving operation, they have a lot of operation afterwards. So the patient has really a lot of other operation, and sometimes the functionality is even not so good, because they have even fracture or something like that. And for instance, as far as the sport is concerned, skiing and so on, my patients, they were also very mobile and could skiing and so on, very, very good. So I absolutely support your decision at that time point.
Awesome.
Thank you. Yeah, it was a good discussion. It took a few weeks to convince the parents, but we got.
Frank?
Yeah, I would also just endorse everybody to think even more about rotation plasty, especially in kids under the age of 10. And just to comment on the comment of Alexander, the preserving of the knee joint will not actually give you a better functionality, and it's actually thought that you will use the knee joint when the hip joint is actually involved, and you have to resect the acetabulum, and then the authors comment that you can use the knee joint as an artificial hip joint as well. So it's not in this case where the acetabulum was free. It's not the preferred from the literal point of view. It's not the preferred option to preserve the knee joint as well. And another comment is, if you really are afraid about stability, you can also use the fascia lata in this case, especially where the lateral compartment was not really a lot involved. So you could use the fascia lata also to strengthen your connection to the joint, and will help you to scar down and give you a little bit more stability for the joint in the first couple of months, probably.
Right, exactly. If it's not involved, and you can see the meniscus there, and what you can see on the bottom right near the thumb and forefinger of, I guess that's me, is the sciatic nerve has to be coiled up.
Yeah.
And yeah, so the sciatic nerve we had a neuropraxia because all that dissection for the entire length of the femur, the sciatic nerve was stunned. It was not very happy, but it did recover. It took a few months.
This is fantastic.
Thanks, Bruno. I have to thank you because this is really ironic. 20 years, like it was your paper. Sorry, your paper that helped me convince the family as well as, to convince myself that this would be the right thing for this patient. So it's funny how things come full circle. No, here we are 20 years later, and what you took the time to write about was actually, directed this case. So it's interesting how we've come full circle, and here we are.
Yeah, it's really very nice, and I think it's even more special if, as you say, 20 years later we can discuss about it, and we can find inspiration. And I also think, we had great contributions today. I learned a lot. I truly hope you can say the same thing about your impression. I just think it's wonderful. I want to really thank all three presenters. You also put in time, and you inspired us too to bring this back in our daily practice as a patient. I thank also all those who spontaneously jumped in and contributed. I just think it's fascinating. Again, if you have suggestions, if you want to present a case, feel free to let me know. We just move on together. And if you want to see it again, go to our YouTube channel, and we just go from there.
Can I just I want to make one quick follow-up. Just before we finish up, to Michelle's point, at the MSTS this year, they just presented some interesting COG data that basically demonstrates that the patients that have the best functional outcome, of all the reconstructive options in these pediatric patients are the rotation plasty patients. So obviously there's so many factors that go into the decision-making for deciding which surgery to do when. But I think from a functional perspective, these are patients that, you know, really can, if they can get over the cosmetic aspect of it, they can really do quite well.
Awesome, Alex. I thank you that you bring this up again. Again, you know, if just by reading papers, we cannot judge. But if we exchange with concrete cases, I think then we can really discuss and move on and learn from each other. And that's what I appreciate so much. Are there any further comments? Then again, thank you so much, everyone, the team, the sponsors, Mar. It was an awesome experience. I was very happy to see you all again, and let's hope we have soon very soon another webinar again. Have a great day or evening or night, and see you soon. Bye.